Dana Miller presents the 9th Annual Obesity Conference, a practical look at obesity, diabetes, and current strategies. Featuring Andrew Storm, MD, Bariatric Endoscopy, New Devices, and the Role of Gastroenterologists.
I'm really excited to hear about this next topic, the next topics. There was a bariatric surgeon here earlier. Has he left? No? One of the things that intrigued me, bariatric surgeons have really sort of ruled the roost, I think, in so many ways over the last 10, 15 years, because they have this incredible, powerful interventions. And they're pretty proud of it. And so when I'm starting to hear about these new endoscopic therapies that are coming out, I think a group just as equally proud are the gastroenterologists across the United States. So I'm, as a medical bariatrician, looking forward to sort of sitting back and sort of watching what evolves. But it's exciting that there's new techniques coming forward that I think will be a great advancements for our patients. So with that, I'd like to introduce Dr. Andrew Storm. He is a senior associate consultant, what they call it at Mayo in Rochester. He is a therapeutic endoscopist. He's trained in advanced endoscopy, gastroenterology, and internal medicine. He's interested in minimally invasive approaches to treating patients, and his research focuses on novel endoscopic procedure and device development. He's a gadget guy, so please welcome Dr. Storm.
That's right. Thank you so much. Well, it's great to be here. Thanks so much again to the Dana Miller team for inviting me. Really a joy always to come back to Philly. I trained actually at Jefferson just down the street, so that's where I did my medical school training. We did talk for about 30 minutes, I think, during our first year about motivational interviewing, so I had at least 30 minutes, maybe more than most of you in your medical training, and then I'm sure it's increased over time because it's really become a standard of care in the way we talk to patients. So I'm here specifically today to talk to you about what I'm trained to do and what I do every day, which is something called bariatric endoscopy. And it's a new term, and I'll do my best to define it and kind of show you where this field is headed. I'm sorry if there aren't any bariatric surgeons here. I know there are some of you that work in bariatric surgery, and so you'll have to take this home. It's usually fun to see us battle a little bit on the question and answer at the end, the bariatric endoscopists and the surgeons. There's no shortage of patients, and so it's not really a battle, but we still usually like to pick at each other a little bit, and I'll throw a couple jabs, even though there's not one here. Maybe I'll throw a couple jabs during the talk. So we'll get started. I have no disclosures to report to you today. My wife sent me this picture just a couple of minutes before my talk, and it was just a reminder that it's nap time in Minnesota, and it's pretty much nap time here, so thanks for sticking with me, and thanks for sticking around. This is our youngest, Charlie, who just fell asleep on the couch. So the objectives of my talk, we'll go through the role of gastroenterology, which is really, I think, positioned to fill the gap in obesity treatment that I'll describe to you. I'll define endobariatrics, these terms that you'll see, I think, probably increasingly in the obesity literature, as well as metabolic endoscopy. We'll talk through some new devices and techniques, gastric approaches. I think it's probably helpful to categorize them into gastric approaches and small bowel approaches because they are different. The gastric approaches are more aimed at weight loss. The small bowel approaches more at metabolic disease. And then a glimpse into future techniques that you'll be seeing over time and probably be sending patients for in the future. So we all know that it's no surprise to anyone here that the global, pandemic of obesity is taking over and causing a lot of death and disability that's changed over time. So just since 1990 to 2015, we've seen a huge increase in the disability-adjusted life years in death related to obesity and obesity-related comorbidities. We've heard lectures about the association with obesity and cancer, chronic kidney disease, obviously diabetes, and macrovascular disease like cardiovascular disease. So how does your gastroenterologist fit in? We're typically thought of, Katie Couric made us famous when she went on TV and did her colonoscopy on the Today Show. And so we're thought of as colonoscopists. And I'd like to try and change that opinion today. But why GI? So we know that there are about 100 million people in the United States that are overweight, that about 88.6 million are in this category of class 1 and 2 obesity, and that 19 million or so are in class 3 obesity and above. And that's a group that may be applied bariatric surgery. Of course, we're only doing about 100 to 200,000 bariatric surgeries a year, so they're vastly undertreating this group. And there need to be more options available to them. And then as we heard today, many different times, we need to be able to treat the comorbidities associated with just being overweight and with class 1 and class 2 obesity as well. And there really aren't procedural options for this group of patients historically. So I'll try to convince you why gastroenterology maybe is going to step in here. So gastroenterologists for a long time have known that obesity impacts the GI tract. We've known that esophageal cancer, stomach, pancreas, liver, gallbladder, colon, small intestine, there are cancers that are highly, highly associated with obesity across all of these organs, and that's been well reported in the GI literature for decades. It's also true that the GI physiology, the GI tract, is key to obesity. So we have domain over endocrine organs like the pancreas. We are involved in studying nutritional homeostasis pathways in the duodenum. And we know that the stomach has a lot of vagal connections to the brain and plays a role in hunger and satiety. So we're already interlinked. And I think what's great about this conference is we're seeing it's a very multi-dimensional approach to obesity that needs to be taken. So what can we bring? Well, we're endoscopists, so we've had a minimally invasive approach, a minimal invasive access to the GI tract for quite some time. And this technology has gotten better and better such that I can hold in my hand, smaller than my index finger, a camera, a channel to deploy a surgical tool, a light source, and potentially all kinds of different tools that I'll show you in a bit. So this is what we bring to the table. What bariatric surgery brings to the table is big incisions. So this is one of my patients who underwent an open gastric bypass, and this is an example of an open surgery. Admittedly, it's becoming less and less invasive. So the majority of bariatric surgeries in the U.S. today are performed laparoscopically, and it's really impressive. And you could never understate how talented that group of surgeons is. But what I'd like to propose is that maybe there's a better way. And I think it's funny that I actually probably have a more scandalous photo in my talk than the sex therapist, but endoscopic techniques don't leave any scars, ideally. We know that the mainstay of obesity management is always going to be lifestyle interventions. So lifestyle is applied to the masses. Medications are becoming increasingly available, thank goodness, and better at targeting obesity. Again, this can be applied to the masses with relatively low risk and kind of modest to low efficacy. And then surgical procedures, there's no controversy here. They're the gold standard to beat. They're the best possible technique, the best way, but also the most risky way to apply to a smaller number of people a maximally efficacious treatment of obesity. So what fills the middle maybe is endoscopic procedures, and that's what we'll talk about today. So to define those two terms that I mentioned earlier, endobariatrics are endoscopic approaches to primary weight loss and transoral revisions after bariatric surgery interventions for weight loss. And metabolic endoscopy is specifically endoscopic approaches to metabolic disease, including diabetes, non-alcoholic fatty liver disease, and steatohepatitis. We've set for ourselves these goals, mostly based on the lifestyle therapy literature, which is that if we can achieve a 5 to 10% total body weight loss, we're nearly guaranteed to achieve macrovascular indices of success in terms of survival and patients' comorbidities. We're almost certainly going to achieve improvements in hepatic fibrosis scores and glycemic benefits. So this is really our bare minimum as we're looking at new techniques and technologies. Just to take a quick detour, one of the early and probably what we spend the majority of our time now doing clinically outside of clinical trials is revision of gastric bypass surgery. And I've kind of heard murmurings throughout the group. This is a group of patients that are really difficult. Bariatric surgery has become incredibly safe. So it's got the risk now, the acute risk of having your gallbladder removed, more or less. So they've gotten really, really good at this, and there's no question that that safety has become less and less of a concern when we talk about bariatric surgery. But there are long-term risks to that, and one of them is that a lot of folks will experience weight recidivism. They'll have a lot of difficulties with weight regain. And so what do you do for them? And it is multidimensional, multifactorial, but one of the things we've seen and shown clearly in the data is that the pouch in a gastric bypass, for example, will dilate over time, and that pouch dilation and stomal dilation, that's the gastrojejunal anastomosis, so what should be a small little opening from the gastric pouch into the small intestine dilates over time. And when that does, it's very, very, very clearly correlated with weight regain and percent regain after surgery. And so since we have this minimally invasive approach to what would be a maximally risky surgery, your first bariatric surgery is actually pretty safe. It's the second one that's going to get you. So the second surgery is associated with a bit more mortality. So instead of being less than 1%, it's more like 4%. And when you have revision surgeries, you definitely need to be with a surgeon who knows their stuff because it just gets tricky. There's adhesions and more long-term complications. So can we minimally invasively affect patients who need a revision? And yes, we definitely can. So we have endoscopic suturing techniques that I'll show you in just a little bit in more detail. But we have ways of revising a gastric bypass surgery where we can perform purse string suturing and sizing over an endoscopically placed balloon. We can do what's called a tubular tori or tubular transoral reduction of a dilated pouch. And this results in excellent weight loss, usually back to where they were at their best after their surgery. And so this is something that's currently covered by many insurance companies. It's performed across the state. UC Denver is one center of excellence. We know I came from a center in Boston where I had done my training at Harvard, which also performs this on a regular basis. And then at the Mayo Clinic, this is something we do every week. I'd like to say that this is the youngest field and that, that it all starts here, but I'm not really on the bottom floor with the elevator yet. We have to go back to the future and talk about the Guerin-Edwards bubble, which a lot of you probably have heard of or remember. So the FDA approved this in 1985. And similar to aspirin that wouldn't be approved today if it had to go through the FDA trials that are required now, the Guerin-Edwards bubble definitely wouldn't have gotten through the FDA today. So it was applied to 20,000 patients over its lifespan. It was withdrawn from the market in 1992 because of big safety concerns. There were gastric perforations, there were ulcerations, there were all kinds of problems with the balloon. It would actually spontaneously deflate in a fairly substantial minority of patients. That balloon then travels into the small intestine and creates a gastric outlet obstruction and a surgical emergency. So this was a well-conceived idea that just wasn't quite ready and had not been perfected before it made it to market. So if you look back at the data, actually, there was no significant weight loss at 24 weeks. So really, again, on multiple levels, probably shouldn't have made it to market, but was kind of where this all started. A company took that technology and has carried it forward. And so in 1990, internationally became available the bib balloon, which is a version of what we're going to see in a second. So to start the technologies section of this talk, we'll first begin with gastric endobariatric devices and techniques, specifically filling or space-occupying devices. And this includes things like gastric balloons. There are now 3 that are FDA approved and clinically available to your patients. There's a single balloon. That's previously the bib balloon that I'd talked about. There's a double balloon, and then there's an air-filled series of 3 balloons that your patient will actually swallow and have filled without an endoscopy to place. There's a transpyloric shuttle that's currently being studied. This is basically 2 little balloons. There's a tiny little balloon that travels intermittently beyond the pylorus of the stomach. That's the sphincter muscle or exit of the stomach, and intermittently obstructs the stomach, leading to satiety and basically just feeling crummy so you can't eat. And that's where this technology stands right now, not yet FDA approved or available. And then there's something called the full sense device, and you can see how people are trying to target physiology, and I think that's what's cool about this. We started doing bariatric surgery not really understanding what we were doing, thinking we were just bypassing and essentially dumping calories that we consume as well as restricting. But there's a lot more to it than that. And fortunately, we've begun to understand that. Well, one thing, this device is trying to target satiety from the nerves that are in the stomach here in the fundus. So by it's basically a gastroesophageal stent that's deployed, and this flange in the stomach pushes up on the fundus and kind of gives you this sense of satiety. And so even though this is minimally invasive, does result in some weight loss. And again, not FDA approved, so we're not going to talk about it yet in much detail, but something that we may see more of in the future. I think it is neat that we're targeting physiology. So the FDA approved intragastric balloons, like I had mentioned, there's a single fluid filled balloon. This is the Orbera. It was the first one made clinically available in the United States by a couple of months. It is FDA approved for an indication of a BMI of 30 to 40 with no comorbid illness. And I don't know how they pulled that off, but they got it approved with no comorbid illness, whereas all the other balloons require a diabetes or obstructive sleep apnea or some other severe obesity-related comorbidity in order to place and be approved. So there's a double gastric balloon that's currently available. This balloon usually filled up to about 750 cc's. This one, 2 balloons. The volume is split, but about 900 cc's in total. And then there are these gas-filled balloons. Again, it's placed without the need of an endoscopy, unlike these other two, but does require an endoscopy to remove. And this is placed and filled with basically a proprietary nitrogen gas. So a chamber of gas that's injected through this small catheter that you can see attached. So the patient will swallow it. There's a cellulose coating to the balloon that'll melt in the stomach, and then it can be injected with this gas and filled. The basic premise of an intragastric balloon placement procedure is going to be shown here in this animation. So once the patient's asleep and sedated with our anesthetist or conscious sedation, the balloon is advanced on the end of a catheter in front of an endoscope. It's then advanced into the stomach. We can be sure that we're filling it in the stomach and not in the esophagus, which you could imagine could be detrimental to the patient. It's then filled with saline, and you can see then it creates basically a gastric outflow obstruction, a bit of delayed gastric emptying, which results in weight loss. The FDA approval for all of these devices right now is for 6 months of therapy. After 6 months of therapy, we do another endoscopy with sedation to go down, puncture the balloon, drain the fluid, and then pull the balloon out through the esophagus. So it does require 2 procedures. This was initially marketed, and I think it was a mistake on the company's part, but it was marketed as really a cosmetic device. Again, for the folks that are not getting treatment otherwise in that 30 to 40 range. But I will say there are increasingly niches, I think, where you're going to see this used in medical disease and medical patients. So this was a patient that I took care of. He gave me permission to share this story with you, and it's actually published in the Journal of Heart and Lung Transplant. But a 45-year-old guy. He was a retired Boston police officer. He had end-stage familial cardiomyopathy, terrible morbid obesity that, despite really maximal efforts on his part, remained with a BMI of about 42. He had uncontrolled diabetes. His A1C, like we'd talked about earlier, we were nowhere near the goals of 7.5 or less. He was up around 13, again, on insulin, really on maximal medical therapy, and just couldn't do better. And then he was on several different anticoagulants, significant blood thinners because of a small stroke that he'd had related to his heart failure. So our bariatric surgeon said there's just no way that we can safely operate on him. And I think that was a fair assessment. But unfortunately, it doomed him to not qualifying for a transplant, which therefore meant that he was headed essentially for his demise. And so because of some of the things that we'd been doing, his cardiologist came to us and asked if there was something we could offer him. They actually came asking for one of the suturing procedures that we had proposed, but we still don't know how safe that would be in the setting of blood thinners. So we proposed a gastric balloon. And you can see here, this is a CT scan, cross-section of his chest. This is looking at him from the side and looking at him from the front. So you can see there's this kind of half of a moon or fluid-filled object in the abdomen. This is within his stomach. And this is the Orbera gastric balloon, so a single fluid-filled balloon. You can see here the valve. This is where the fluid is put in. And then you can see there's something bright in his chest. This bright white thing is a left ventricular assist device. So his heart failure was so bad that he actually had a propeller in his chest that had been implanted, like Dick Cheney, I guess, to continuously cycle his blood throughout his body to keep him alive. So his heart failure was real. It unfortunately contributed to just not being able to exercise. And so for all of these things, for all these reasons, he was not going to be a heart transplant candidate. So we put the balloon in. It was a bit of a Hail Mary pass, but we saw some really impressive results. And these are in line with what we see in the clinical data with these balloons, though not usually in a heart transplant population. So the solid line here is his body mass index, and the dotted line is actually his fasting serum glucose. And so we saw, this is just kind of watching him just to show you that he was plateaued for a period of time and really not making any progress. When we placed the balloon, we saw immediate decline in his fasting serum glucose. You can't really monitor A1C in these folks because of they have so much bleeding with their blood thinners and such. Their blood turnover would give you a falsely low A1C, but we chose fasting serum glucose, which I think adequately represents and appropriately represents his actual glucose homeostasis. And then the body mass index just fell precipitously. And you can see here, it was about a month before we took the balloon out that his heart failure had gotten bad enough. And they were thinking he might make it to a heart transplant, that they actually put in a left ventricular assist device. That's that bright thing on the CT scan that we saw earlier. And then we removed the gastric balloon, and just a few months later, so he had been listed for heart transplant before we removed it, we started to get an inkling that, I hate to be morbid, but at the next motorcycle accident, he was going to probably be the next guy up. And so we took the balloon out, and he got his heart transplant just 2 months later. So just an example of maybe a niche, maybe an early example of how this therapy in particular may be applicable to medical disease. Another niche, there have been studies on infertility. You can imagine there's a lot of people out there that need to lose weight in order to get their bariatric surgery, or maybe to get their knee replacement surgery. And so infertility is one of those things. We spend a ton of money as a society on infertility, which is sometimes due to the endocrine effects of obesity causing anovulation. So this retrospective study compared 86 different surgical therapies, which was nearly an even mix of Roux-en-Y, gastric sleeve, duodenal switch, and then the intragastric balloon. There was no difference among all of them in reversing infertility and achieving a full-term pregnancy. They were all effective, and only having a BMI loss of 5 kilograms per meter squared was predictive of success. And this is something we know, from the literature. This is something you could have predicted. That just a modest amount of weight loss will reverse a lot of infertility. They did a follow-up study of 27 additional obese patients with infertility, and they saw that, again, about 55% success in full-term delivery just using this. So rather than applying $40,000 to $150,000 towards fertility treatments, potentially in someone who you probably don't want to do bariatric surgery on. These patients, by definition, are not bariatric surgery candidates. The degree of malnutrition that's going to be experienced after bariatric surgery basically makes the idea of having fertility within 2 years fairly low. This may be, for example, a group of patients that would really benefit from gastric balloons, and I think we'll see this may be one of the first groups that's going to achieve insurance coverage of this device. This is a different balloon. It's from Israel. We led the study, actually, but a multi-center study that's going to be reported soon. This, you can see, it has a fishing line loop, basically, on the end, a polypropylene loop that we can grasp, bring out through the patient's mouth, and adjust over time. I think the downside here is by definition, you're committing a patient to multiple procedures over time, but you can actually adjust the balloon. The biggest problem with balloons is that your patients are going to call you or me right after they've had it placed, and they're going to be miserable. Up to 10% in U.S. studies and real-life studies will actually have their balloon removed within the first week or two, and that's usually because of the issues with nausea, vomiting, issues of their stomach trying to accommodate to this balloon. And so this probably cuts down on that quite a bit. This allows you to start with a modest volume that's going to result in early weight loss, but then you can actually fill it over time. This balloon is also approved internationally for a full year of therapy, which is what we would anticipate it would achieve in the United States as well. So the pivotal trial data, it's 100% enrolled. We're finishing up collecting our data now, and this will be reported if I'm lucky enough to come back and speak with you in a year or two. This we should have final data on. Will probably be FDA approved by that point. Another exciting twist in the story is a completely procedureless balloon, and this is totally game-changing. This brings gastric balloons to everyone's clinic. So this is a balloon that's placed just with your patient sitting next to you. They swallow this pill capsule. It's marked with kind of hashtags to tell you how deep it is. Just like with a nasogastric tube, you can predict when it's in the stomach, and then you can actually fill this slowly through this kind of capillary tube. This can be done, again, without any procedure to place. And then this is where it's really a game changer. Again, coming out of Harvard Medical School, 2 med students, they actually dropped out of med school 2 years ago to take this to market. But they made this balloon that self-deflates. They worked with engineers at MIT and came up with a valve that slowly deflates after about 4 to 6 months of therapy. This passes then through the pylorus and out in your stool as if you'd swallowed a huge hunk of gum. So this, again, huge game changer, and I'm sorry to say, takes it away from the gastroenterologist, because now all of you can do this in your clinics, absolutely. And so you may see obstetric gynecologists doing this for their patients with infertility. I don't know, but this is a great future. This is really great. I had told you our goal has always been 10% total body weight loss, and I truly believe, and it's our practice, my partner and I, actually the lead author on this, Dr. Abudaya, Barham and I feel that if it can't achieve that 10% total body weight loss, we're probably not going to offer it at the Mayo Clinic. And so the balloon that we offer actually did achieve that. So the Orbera balloon is what we tend to prescribe to patients. These other balloons still, there's more data, and certainly if they were to cross this line, if we had something that tweaked about them that allowed us to achieve the weight loss we wanted, we would move towards some of those things. But this is the balloon we offer. Again, I receive no royalties and have no research support from this company, but this is the balloon we offer. They've achieved at least the 10% total body weight loss in their pivotal trial that led to FDA approval. And then we also see great glycemic benefits. This is in all comers, the hemoglobin A1C dropping in a statistically significant fashion from nearly 7 to 6.1. When we look specifically at diabetics in a little bit, we'll see that it's an even greater effect. There's also improvements in liver function tests, as you would expect to see with regression in hepatic fibrosis, with weight loss, also blood pressure and fasting sugars. This is just a study to show that once the balloon is removed, for reasons we don't understand, but probably related to patients' change in the way they eat, there is some persistence and even some data suggesting ongoing weight loss after the balloon has been removed at 6 months. So this is looking at total body weight loss. At a month with the balloon, it's about 4.8 total body weight loss, 8.8 at 3 months, just shy of 12% total body weight loss at 6 months, and then it continues after balloon removal at 13 and just shy of 15. And long-term data beyond that is certainly soon to come. The next category of procedures is gastric remodeling and plication procedures. Primarily right now, this is an FDA-approved device, so this is something we're doing every week at the Mayo Clinic as well. This is a procedure whereby we use endoscopic suturing, so all through the mouth, to actually reduce the size of the stomach, very similar to a sleeve gastrectomy, but we don't remove any stomach. So it reduces the size of the stomach to about a 90% reduction, again, but without removing the stomach. Essentially, though, looking very much functionally like a gastric sleeve, surgical sleeve. And then there's another procedure called the pose. It's not yet FDA approved, but is a study that we'll be leading in the coming year, where we we'll be looking at this device that's used to make plications and reduce and probably affect the fundus as well as gastric outlet flow and gastric emptying, similar to the effects that a balloon would have on the stomach. And so that's something we'll be seeing in the future. So the sleeve gastroplasty, and I'm excited to tell you about this because this is probably our best procedure right now in terms of total body weight loss. By far, this is the one that it doesn't make surgeons nervous, and it really shouldn't, but this is the one that's going to compete, so to speak, with bariatric surgery in some ways. The sleeve gastroplasty, you'll have to take my word for it if you're not an endoscopist, but this is a very normal looking stomach. When I come down through the esophagus into the stomach, this is what I see as a normal stomach. And so using this tool, an endoscopist was touring a furniture company in North Carolina near where I was born, and they saw the last stitches being put in a mattress in the corner with this long stick with a suturing arm on the tip. And they said, boy, we could miniaturize that and use it to suture in the GI tract. And over the course of the next 10 to 15 years, Some of my mentors from Hopkins had actually developed this device, and it's now fully FDA approved and clinically used to plicate in the stomach. And it allows us to pass this suture with a polypropylene thread back and forth. This Helix device is just like a corkscrew that our server will use next door after these talks to open a wine bottle. So there's a corkscrew that's twisted into the gastric tissue. It grabs the muscle layer, pulls it between this jaw, this suturing arm, and then we can fire a suture and then grab it and exchange it back and forth and actually do a running suture. So it was initially designed with the thought that we'd be repairing gastric perforations, which we do. Again, in Baltimore, that's more of an issue, lots of stab wounds and such. So they were trying to make, a minimally invasive approach to repairing tissue. But we've also found it can augment tissue and specifically result in weight loss. So this is the procedure. In diagram, we can actually go down with the device into the stomach and use a triangular suturing pattern that will then reduce the stomach. So the suture's tightened and cinched, and I'll show an animation of that as well. So this is the stomach. This is my patient's stomach to begin with, and this is her stomach actually at the end of the procedure. So you can see there's a dramatic change in the diameter, in the size and volume of the stomach. And this looks to me like someone that I am performing an endoscopy on who just had a sleeve gastrectomy. So it's a very similar kind of effect. This is an animation of the procedure itself. So an endoscope is passed with the suturing device on the tip down into the stomach. Early on, 5 to 10 years ago when we were starting this device, mostly in studies at that time, in order to kind of map out where we would be suturing, there were some cautery used to draw lines and essentially delineate where we wanted to reduce the stomach. We've now gotten good enough at it. We don't usually do that first step that was just shown. But then we, again, draw up the tissue and place sutures, full thickness sutures. So when we do this in animal models and when we've done it with laparoscopic assistance in the OR, we see that the suture is passing on the other side of the stomach. So it really does, the suturing goes out to the serosal side of the stomach. That suturing sequence can be repeated multiple times and then reinforced even with additional sutures to result in that 90% reduction in the stomach lumen. So that's the sleeve gastroplasty procedure, and I think this is probably the one to beat when it comes to bariatric endoscopy. It's a little more invasive. We are driving a needle through the entire wall of the stomach, so that's the reason why we avoided it in that man with blood thinners, for example. But in an otherwise normal, relatively healthy patient who needs to lose weight and would qualify for bariatric surgery, this is a potential option. This is a 3D reconstruction of that patient that I'd shown their stomach both before. So this is the volume of their stomach before, and then again after the sleeve gastroplasty procedure. So just showing the impressive reduction in volume. The other procedure that I'd mentioned, again, this is more for the future, and because it's not FDA approved, we won't talk too much about it, but this is kind of the basic mechanism for how it fires these full thickness plications. This does not allow for running sutures. It's not as surgical as the other device, but does allow you to reduce the size and flow of the stomach. There are other devices that I just want to mention to be complete. These are available internationally, but not in the US, and so there may be other things that we'll see in coming years as well. So the state of the evidence is great for these remodeling techniques. We're seeing with sleeve gastroplasty total body weight loss at a year approaching 20%, which is really what we want to see. I also want to show that across multiple centers, we're seeing similar results. This is not just a Mayo phenomenon. This is not just a Boston phenomenon, but across multiple centers, we're seeing that weight loss is pretty good. These are 3 different centers at a year. Then again at 6 months, then again at 1 year, and then 2 of those studies have data out to 18 months, and we'll continue to have more data as time progresses. The impact on comorbidities is impressive and maybe what you would expect. So hemoglobin A1C for all comers significantly drops 6.1 to 5.5 in our cohort. We know that in diabetics, this was an A1C of 6.6 to start on average down to 5.6, so a full drop. That's what you'd expect with like a really good anti-diabetic medication to get 1 full hemoglobin point drop. Waist circumference, systolic blood pressure, cholesterol, and liver function tests all drop impressively. The last, and this is the this is the one that I usually get questions about, and we usually have to talk about at the end a little bit. This is a device that's received a lot of mainstream media attention. You may have heard of it, you may have seen this before, but and moves maybe a little bit into the realm of the prior talk, in that this is a device that's placed with the intent that a patient will eat and then remove some of what they've eaten from the stomach. And so the premise of this device, which is FDA approved, has excellent clinical data, very impressive weight loss results, approaching and actually sometimes doing quite a bit better than sleeve gastrectomy, for example, is placed similarly to a PEG tube. So if you send your patient for a feeding tube for nutrition, it's the exact same thing. It's slightly larger caliber. Rather than calling it a PEG tube, it's called an A tube for aspire or aspiration. But it's placed with an endoscopy, so it's a non-surgical procedure. This tube extends into the stomach. It has multiple side holes that allow it to suction stomach contents out. There's a small button, plastic button that's on the anterior abdomen. That can be hooked up to a device that's carried in a small pouch by the patient. You can turn it on. This allows the flow of gastric contents, so intra-abdominal pressure just pushes the contents out. I love the shaking heads. And then the food contents come out and empty into the toilet. So you have to have a stomach for it. And then there's a reservoir of saline. You can just use tap water that's flushed forward into the stomach, and that allows you then to remove a couple more times. So there's a limit on the number of times this device can be switched. So it does have a counter, and it does limit the number of times within a given day that the patient can use the device. But it does allow you then to wash out. And on average, patients are removing about 30% of the calories that they consumed in a given meal. The weight loss there, again, is fairly impressive. So especially, usually in Europe, they do quite a bit better than us. But in Europe, the weight loss was approaching 20-25% in some of their follow-up data, total body weight loss. Again, similar to that of a sleeve gastrectomy. Definitely on all counts above the 10% kind of bare minimum that we'd like to see to achieve those macrovascular benefits. So cardiometabolic improvements are significant. Hemoglobin A1C trending from 6.1 in all comers to 5.8. It was significant. In participants with diabetes, from 7 to 6.3. So again, getting just about that full point reduction that you'd like to see with a really powerful anti-diabetic medication. And that's what we'll say for now. This, again, the Colbert report and some other folks have come after it. I think the one thing I would say in its defense, and it's all that I'll say for today, is that it really does require quite a bit of input from the patient. So unlike a bariatric surgery, which you perform, and then you could say, and I heard some people talking about this, your patient comes, they get the surgery, and then they walk away, and they kind of expect results. This, they can't do that. So they really have to have a lot of buy-in. They really have to use it every day. They have to be religious about it. They have to be incredibly intentional about chewing their food well, or the tube will clog and it won't work for them. So I like to hear the psychologists actually debate about this device, because there are some of them that say this is actually much more healthy from a mental standpoint than bariatric surgery. And there are those that say absolutely not, this is purging behavior. And so I think that's a debate that still needs to continue. And endocrine societies don't like this device as a whole, I will say. For me, from the data standpoint, it works well, is very safe and minimally invasive. So it's something that potentially can be offered to patients, I think, with a sound conscience. But this, even though it's FDA approved, is still kind of to be seen how it does. We'll move on then to small bowel devices. And this is pretty exciting. This is where we get into the realm of more diabetes, fatty liver disease. This makes the hepatologists, when I talk with them, more excited. So the duodenum, we know, is at the center of metabolic control. There are enteroendocrine cells in our duodenum in the early small intestine, just beyond the stomach, that sense nutrients. They send signals that control insulin and satiety over time. And so this organ, or this part of the small intestine, this part of this organ is very important, maybe more important than we ever realized. So how do we target, how do we harness the power of the duodenum in treating metabolic disease? And that's what some of these devices have aimed at. So these are called duodenal sleeves or duodenal jejunal bypass sleeves. So there's a nitinol, kind of as if you're going up into space in the shuttle, but there's a nitinol stent that's placed just in the end of the stomach. And then there's a Teflon sleeve that extends down into the small intestine. And the goal here is that all food and fluid contents of the stomach, so anything you eat or drink, is going to have to pass through the stent, which is deployed endoscopically. You can see there's an endoscope here kind of watching the deployment. This is how we would deploy a stent for a duodenal cancer, for example, to open up the duodenum and allow someone to eat. But the stent is deployed again here in the stomach. All food and fluid contents pass through and are excluded from absorption, specifically in the duodenum and the jejunum. And this, similar to bariatric surgery when it first began, we don't completely understand why this works, but it seems to work pretty well, especially from a diabetes standpoint. Unfortunately, and the reason I don't have a lot of data here is because the FDA approval study was halted early because of 3 liver abscesses that occurred. The device was probably left in too long, and the nitinol stent mechanism here is fairly traumatic when you're removing it, and that's probably what caused these few issues. So it's less than 0.01% of getting a hepatic abscess based on that data, but it was still enough for the FDA to say, oh, we better retool this, we better rethink this, and come back to the table when you've got something better. So they're coming back to the table actually right now, and I think, again, this is a device that'll go to clinical study and then probably become available in some form in the near future. Small bowel ablative techniques, this is really interesting to me as well. So again, targeting the duodenum, there are companies which have said, well, let's not put in a sleeve. Let's just ablate the duodenum. You know, we're really good at ablative technology. Interventional cardiology and electrophysiology have done this in the heart safely. Why can't we do this in the small intestine safely? And so this is a device that's placed, again, endoscopically and under endoscopic guidance. There's a catheter that extends and creates a submucosal, so kind of the skin layer of the duodenum is injected with saline to lift it away from the muscular layer. And then we can safely ablate that superficial mucosa, again, kind of the skin level of the duodenum. And that destroys and sort of hits the reset button as if my computer weren't working and I decided, well, I can't blow on it anymore, but I can turn it off and turn it back on. The thought being there that we're turning off and turning on whatever these systems are that work in the duodenum. So again, not super well understood, but a technology that works remarkably well. So this is what it looks like. This is a normal, healthy duodenum with an endoscopic view. This is after treatment, and then this is just 3 days later. It's completely healed up. And despite it looking back to normal, there are big metabolic changes in this patient. So we see that in a higher pretreatment A1C group, there are drops in hemoglobin A1C, specifically in those that had an A1C to start above 11, down to less than 8. And this is very interesting. And again, I think we don't fully understand why this happens, but really impressive improvements in hemoglobin A1C. This is of interest, especially the endocrinologists at our hospital are interested in moving these studies forward to figure out why and how and what role and maybe new and better ablative techniques to achieve these results. There is other data that's maybe less impressive in terms of an overall delta change in hemoglobin A1C, but that suggests that the durability of the procedure is quite good. So this is another one that we don't have long-term data. We don't have enough big data for me to report it to you in a statistically significant way, but this is definitely something that'll be coming to the table soon. And then, since I'm just talking about new devices and techniques, they all are GI so far, but I do want to highlight that the cardiologists have also caught on to this. And so their realm is to access people's blood vessels from their femoral artery and femoral vein. And so they've come up with a way to target the GI approach to weight loss and metabolic disease by a catheterization system that's actually used to enter the femoral artery and then comes up, again, to kind of our realm in the celiac trunk and to ablate the celiac ganglia, which is a set of nerves that innervate with sympathetic tone multiple different metabolically active organs in the abdomen. And so, again, I think we don't fully understand what we're doing here, and it gives me a little bit of hesitancy. But the study, the complement trial, is actually underway in New Zealand with early results looking very positive from a metabolic standpoint. Their device, by the way, is called Metavention. So something just to watch and see in the news, because it'll be out there. And then lastly, this is kind of the most sci-fi-y, I think. This was a thought process from my former mentor in Boston. Is there a way to harness and then recreate the effects of a gastric bypass without actually doing a gastric bypass? Kind of the most maximally invasive procedure there is, of course, is a gastric bypass, whereby you move the vast majority of the stomach off to the side. You have a small gastric pouch, and then a roux limb that supplies the juices from the bile and the pancreas. How do you harness this, which clearly has some magic sauce with it, that results in weight loss above and beyond what you would expect, just based on the amount of calories that a patient can no longer consume? So this bile diversion clearly plays a role in weight loss, which I know we heard from earlier talks this weekend. Plays a bigger role than you would expect. And so how can we harness that from an endoscopic side? And that's what this next device aims to do. So to recreate this anastomosis, we've thought about deploying magnets. Magnets, one from above and one from below. They meet each other and actually form an anastomosis in the small intestine. And I'll show you how that works. So this is in clinical studies in Europe now. And so this requires 2 endoscopists, 2 cameras. So there's a colonoscopic exam. So the colonoscope is advanced all the way through the brown, that's the large intestine or colon, into the small intestine from below. Another scope is advanced through the stomach into the small intestine from above, and you can actually see the light shining at each other. So you can see these 2 scopes meet. This is it on fluoroscopy as well as live endoscopy. So we push out a string of magnets that self-assemble into a ring. And these can be manipulated using, again, fluoroscopy down here, or X-ray guidance. We can manipulate the patient's stomach with external pressure and find these magnets until they meet each other. Over the course of several days, there's a compression anastomosis that forms. So the tissue between the magnets is not getting blood, and so it dies and falls away. And you actually get a very durable, fairly large anastomosis that forms between the two, and thereby you shunt about 60 to 70% of all food, fluid, and bile from its natural flow through the entire 20 feet of small intestine straight to the terminal ileum and colon. The colon, of course, being unable to absorb nutrients. It's really just an organ that absorbs water. So this is interesting. And again, clinical data will be available soon. All we have right now is animal data, which I didn't feel like was worth showing you, but it's maybe it's kind of a cute picture. There's a pig that was treated with it and a pig that was treated without it in a juvenile stage, and you see that the growth and the girth of the pig is just impressively different. And so that initial animal studies were very positive, which led to these early Europe studies of this American-made device. So what is the future of endoscopic bariatrics? Well, it's here to stay. There are definitely some techniques that I presented to you today that work really well and are being applied to patients all over the country and internationally. I think the future is really, how do I identify the ideal candidates? There are some people with these minimally invasive approaches that actually achieve bariatric surgery level weight loss. And so how do we find them and identify them and maybe save them a maximally invasive surgery, the cost, the morbidity that's associated with that, and bring them to an endoscopic approach? And then how do we also find folks that are not going to benefit from either, and potentially keep them and our society from spending the money on the procedures that maybe aren't going to be helpful. And so this is something that colleagues at the Mayo Clinic and other institutions, especially, I saw Lee Kaplan had been on the speakers list, but wasn't able to make it this weekend, but he's a big player in that as well. And so how do we identify these high performers? Is it through imaging? So we're doing gastric emptying studies and identifying patients who are going to qualify and do very well with endoscopic approaches to reducing gastric outflow. We can look at genetic testing and microbiome. These are all for the future and are in research now to identify what your patient is going to best benefit from. And I think that's the future is precision medicine in obesity. So in case there are gastroenterologists in your group, maybe a friend or colleague that would be willing and able to help out in the future, there's a lot of resources out there. So I put these in the slides, which should be available to all of you. And again, one of my colleagues at Mayo, Andres Acosta, has put together with the American Gastroenterological Association this Power website, which just helps the gastroenterologist who traditionally is not involved in weight loss medicine, in obesity, gets them involved and shows them kind of how things should work. I think it's particularly important that we don't just become endoscopists out in surgery centers doing these procedures. This is something that needs everyone's involvement. It needs to be done at centers of excellence and when we have proper nutritional support. The American Society for Gastrointestinal Endoscopy also has a lot of patient handouts and information about these procedures, offers a lot of education for endoscopists that may be willing to step into this realm. And then there's actually a society that's been formed, the American Bariatric Endoscopy Society. This is their website. There are fellowships available. I'd highlight ours at Mayo and others across the country, which will teach these techniques to people in medicine that are interested, not necessarily endoscopists or gastroenterologists, but those that are passionate about making this field move forward to help patients. And then I think this is really interesting. Board certification in obesity medicine has been available for a while. 5 years ago, there were no gastroenterologists, and now there's 50 as of the website when I checked last night. So this is something that's catching on, and I think more of us are going to become in tune with helping with obesity management. So in summary, the GI tract is front and central in weight and metabolic regulation. There's now level 1 strongest evidence that endoscopic bariatric techniques will help your patients achieve significant weight loss and metabolic improvements. There are a variety of devices, techniques, and providers that are growing in number to meet the demand of the obesity epidemic. And the potential advantages, which I think patients are really going to like and prefer, is that it's safe, it's repeatable, it's combinable. So you could maybe do that magnetic anastomosis plus a sleeve gastroplasty. You can do these things sequentially, and they're very cost-effective being performed in the endoscopy suite as compared to in the OR. So that's the conclusion of my talk. I'm happy to take any questions.
This has been a Dana Miller Video Network presentation.